thank you for your great talks, Polly and Richard, and also for your comment. I think there's nothing left to say. It's just right. We need comprehensive care structures which are paid and which are for everyone at the hospital. We lose about 40% of adolescent patients with chronic diseases on their way to adult medicine, which in some cases leads to deterioration in healthcare. To improve this, a structured and planned transition process is required. This must include not only medical concerns, but also psychosocial, like family, individual situation, educational and vocational aspects. Studies show that a transition program that includes psychosocial aspects has reduced the rate of patients leaving specialized care from about 75% to 11%. I think the numbers are very impressive and shows us what to do. Let's have a look at the situation of this patient group we are talking about. Young people who are on their way to get adults. What is special about this time? And what does it mean for us? We are working with them. Adolescents, we are speaking about the age range from 12 to 29 years. And 29, it's such a long time because the time to get independence in financial ways, it gets longer, is probably the phase of the life that comes with the most far-reaching changes in both physically and psychologically and socially. They have a lot of developmental tasks to solve on their way to becoming adults, with the goal of finding their identity and become autonomous. In an ever faster changing world, which is increasingly characterized by crises and wars, and an encompassing technologization, this represents a special challenge. Growing up does not happen automatically, but it's an active process. They have to find their solution strategies to get adult. Oh. Sorry. Now I'm in the wrong. Now I'm.
It's okay.
It's okay. Thank you. Today, there are many good medical treatment options are available, but rheumatic and autoinflammatory diseases not only affect physical health, patients face a variety of challenges that affect their psychological and psychosocial health. In addition to the usual development tasks of their age, they must also master the challenge of their chronic disease. This has immense consequences for the health-related quality of life, even if the process at the receptor level functions smoothly and the inflammation level is low. This is especially true when patients have to live with their disease for many years. This affects a large proportion of our patients as they are dependent on medical care in adulthood. Children and adolescents with a chronic disease have a 3 to 5 times higher risk to get a mental disorder. But health-related quality is today an important measure to get the impact of the medical treatment. So, what does this mean? In order to be able to assess, understand, and treat psychological stress in chronically ill children and adolescents more quickly, COACH, a multi-center study was conducted by the University of Ulm in collaboration with the German Rheumatism Research Center Berlin. 1,150 patients were with a chronic disease aged between 12 and 21 with diabetes, cystic fibrosis, and SHORT-IA were screened during their outpatient appointments with the questionnaire GID-7 and PHQ-9 regarding their mental health. The goal was to find better ways to understand the psychological stress of chronic disease and to recognize it at an early stage and thus to be able to treat it in an optimized way, as well as the influence of motivational interviewing on the part of the doctors at the use of psychosocial support were asked for. The results of the study, a high prevalence of ADHD and depression symptoms were uncovered, and the underuse of mental health care and need for routine screening to detect the stressful situation become obvious. The result of the study confirmed the experience we have in our center. We are aware that the stress have an impact on the self-management of the disease and the ability to treat. In fact, of this, we support all our patients since about 24 years in multi-professional team. Since about more than 20 years, we have a transition clinic in cooperation with the adult rheumatology of our hospital. As pediatric inflammation center with the pediatric rheumatology and the autoinflammation reference center, we are part of the Center of Rare Diseases at the University Hospital Tübingen. Together with these departments, we are an interdisciplinary clinic called Indira. In this network, we can provide interdisciplinary, and in this team, we can treat patients in cooperation and collaboration with the various disciplines. In addition to the diagnostic and drug treatment, our structure also includes psychosocial care. What does this mean? All our patients and their families should have the opportunity to present themselves at our consultation. The aim is to identify psychological and social stress that can arise in connection with a disease and its consequences at an early stage, and to include them in care. The process of coping with a disease can be supported by the diagnosis can be processed and sorted in one's own life. Self-management of the disease is promoted by developing psychosocial and emotional coping mechanisms. For everyday life in family, at school, at work, and in the social environment, concrete strategies for action and solution can be developed together. The aim is to empower the patients and their families. To do this, they need knowledge about their disease and information about support services. Those who understand their disease can deal with it responsibly, communicate with their environment, and develop strategies for a good life. Our team includes pediatricians, internists, a case manager, nurses, a physiotherapist, teacher, and 2 social pedagogues with therapeutic trainings. We meet 2 times a week to discuss the individual patients with their medical and psychosocial aspects. The central task of the psychosocial service is to grasp the complexity of the psychosocial burdens that can be associated with their disease and their individual life situation. For a successful treatment and coping with the disease, we have to take in account disease-dependent and disease-independent aspects that enable patients and their families to take adequate care of health. For example, if a teenager is struggling with bullying at school, or if a family has an emotional stress because the parents are separated, or if they are afraid about that they can't pay their flat anymore, they can take care of their health like they have to. Adolescence is the time of change, and so the understanding of the disease also changes. The thoughts go into the future, and the awareness develops that the disease may be their companion for life. Chronic disease brings special challenges for many adolescents and their families, which they have to cope with in everyday life, in addition to the usual challenge and development. And often the health issues compete with the demands of the development tasks, like sleeping less or do too much sports, test drugs, pushing limits, not wanting to be under control all the time. And we have to know in our contact with the young adults that they have a special risk behavior in this time when they get adults, and therefore they need to have this risk behavior, that they have the courage to get adults. So what does this mean for our work? Transition is a process of change that starts early. The first step is the integration of the patients as early as possible. That is change from the parent to the family clinic, giving the patients more responsibilities during the teenage phase. The transition clinic starts, ending with a transfer to the adult care. During the transition clinic, the young patients should learn to make their own decisions together with their parents. This needs a special framework. I will now tell you the transition clinic from Tübingen, and I will skip you the details. At the age of 13, the psychosocial services introduced the concept of the transition clinic to the patients and their parents and discussed the first appointment in the medicine consultation. We train the situation, how can they speak, how can they talk, what may be their questions to the doctors. And we decide together if it's the right time to change in the transition clinic, and it depends from the stage of development of the patient. We have one clinic per week exclusively for the adolescents, and runs with an adult rheumatologist joining the pediatric team for the patient's visit. Every Tuesday there is an interdisciplinary and multi-professional team present. The day starts with our weekly assessment within the transition team of physicians, nurses, and the psychosocial team. The visit starts without parents to practice autonomy and continuously transfer the responsibility from parents to adolescents. It is also easier to address youth-specific issues like drugs, friendships, or contraception, but the parents are still part of the care concept. Studies show that adolescents remain passive during consultations when parents are present, despite having good social skills. When treating adolescents, practitioners and parents tend to cooperate with each other. That there are studies about. There are regular visits with the psychosocial team to educate in understanding the disease, to train their self-management, to develop action and coping strategies, to learn to deal with stress, to learn to communicate about their needs and also their problems, to stand up for their interests, also in the consultation hour, to receive information about social law, in short, to receive knowledge about all areas of life, to be able to develop the ability to act. Often we also discuss the appointment in the consultation or deepen topics that were addressed there. They learn that a visit in the clinic was useful and good when they understand everything and were able to address their question in the consultation. For the consultation, we have a guide, a checklist like a guide, but the first issue, it's all the time the current issues the patients will bring in. And often it's a great theme that the adolescents has the chance to sort their thoughts and their feelings in the consultation. And I think because before the question was how what shall we do when they don't want to come to the consultation, and if there is a structure where it's normal to come every appointment, also to the psychosocial care, it's normal. They learn it, that it's just they can come, and one appointments, they have to talk a lot, and then there are some appointments I don't have to say anything. But so it's normal, and everybody learns to talk about the situation and to give them place. We have also a clinic school, and there they can address their questions and concerns, their daily life at school, to talk about and to get their rights and to get the possibility of an equitable access. Then we have training and information additional from the patient days, one time a year. We invite all the families with their patients to come to the hospital, and there we give some talks to themes they wish to talk about or hear something about, and they have the possibility to meet each other, to get in touch together. And we are part of the transition camp at the Lake Constance from the beginning in 2009. Here have the young adults the opportunity to exchange experience, make new friends, receive and discuss new information in workshops on the topics like living alone, communication, sports and exercise, family planning, education, and much more. But above all, it is very important that they should have fun. In the end of the time, we start with the age of 13, and if it's possible, they leave with 18, perhaps 19. We do a questionnaire to look if there are still some more subjects we have to work on, we have to give more support. And at the end, we try to plan the transfer together. We discuss it in the team, but also with the patients. The aim is to empowering the patient that they know what they have to know about their disease and the treatment, so that they can be a part of the decision for the treatment. They have to learn, communicate strategies concerning all areas of life. They need knowledge about information and support for school, studies, education, and their profession. They need coping strategies for pain and psychosocial psycho-emotional stress, and we have to perceive and strengthen their personal resources. And the aim is to get an autonomous and independent dealing with the disease and their everyday life. Living with a chronic disease is full of challenges. As a team, it is our job to support them to find the balance between the challenge of growing up, everyday life, and managing their disease. Within the framework of a doctoral thesis, we had the chance to evaluate the concept of our consultation hours. About 18 patients were asked half a year after the transfer. Positive effects of the healthcare transition program on long-term outcomes could be identified. Patients' overall satisfaction and self-perceived self-management skills were high, and in general, patients felt well informed and appreciated the individualized approach. And we have seen that a lot of the patients reached the adult medicine. The working group of the Society for Pediatric and Adolescent Rheumatology is a multi-professional team whose members are working in various institutions throughout Germany. Our goal is to go further, develop a structured transition process with binding standards. We meet 2-3 times a year and bundle activities, develop and bundle instruments for a structured transition into the clinic routine and its evaluation. And I think the key element for a successful translation is to have a structure with a multi-professional team, with a, and I think this is the base, and we need the money for it to adapt these structures. And so to take all with in this process, we have to reduce the rate of patients we lose to adult medicine. We need structured programs, take that into account, that the individual situation of this phase of life and its specific problems related to chronic diseases. We have to do routine screening in mental health, and we need the recognition of transition as a service in standard care in order to enable a multi-professional standardized procedure. Therefore, we need a team to work together, and I think our job is it to help the young people, the young adults, to get their balls in the air, and if they're dropped down one ball, we have to help to get them up. Thank you very much.